All right, so welcome everyone to today's AI Insight series, and we're really excited to have Dr. Jessen Schiebout as our guest facilitator, and I'm going to hand over the conversation to Jessen. I'll keep an eye on the chat.
Great. Hello. Again, my name is Jessen Schiebout. I'm one of the attendings in the emergency department. And today we're going to discuss different applications, AI applications in clinical medicine, particularly where that intersects with medical education. The lecture is kind of divided into 4 different parts, which loosely correlate with our objectives. So today we'll look at the current state of AI in healthcare and education. We'll discuss real-world examples and some limitations of AI implementation in different clinical settings. Particularly, we'll illustrate the importance of maintaining clinical reasoning and critical thinking skills as we go through this. We'll talk about different strategies to prepare our learners for the upcoming AI-augmented healthcare environment. And at the end, we'll briefly discuss some ethical considerations and some challenges. So the current AI models, the new thinking models that have come out more recently over the past couple of months, I think are closer to what we all were hoping ChatGPT would be. They're more accurate, they do a better job kind of explaining things, they give better answers, but the outputs from these tools are still nowhere near the burden of proof required for scientific or clinical practice. So if you think about it, the current models that we're using really aren't as intelligent even as your home pets. And this is actually, I've poached this from Jan LeCun, who's an AI researcher. But so he gives an example where, according to the state of Illinois, for example, a teenager requires 20 hours of driving experience to be able to learn how to drive a car. Meanwhile, AI has billions of miles covered, and they still don't have full level 5 autonomy. If anybody in the audience has toddlers or children, you can kind of think of an example where maybe you teach them to clear the dinner table or take out some garbage. You may not even necessarily need to show them how to do that. They can figure that out on their own. That would, in the AI world, that would be called zero-shot knowledge. Or even if you teach them and give them examples at home, once you go to grandma's house, they can kind of apply that knowledge to a new setting and clear the dinner table or take the garbage out there, where AI doesn't really have this contextual ability to adapt to new circumstances. AIs don't really have this kind of world model. So these systems in some ways are very smart, but in other ways, they're not very smart at all. They kind of lack this critical thinking ability and that world model understanding. This is improving. In a couple of minutes, we'll look at kind of some of the scaling laws and things that are going into the improvements, and we'll talk about how rapidly some of these things are changing. But even as these systems improve and get much better, they're still likely to make errors, and errors at a much higher rate than we do as clinicians, for example. And all of these issues, with contextual understanding are separate from other problems that these models suffer from, like hallucinations and bias. And we'll kind of go over some of those. So I've read that the combination of the hardware and software improvements are effectively yielding a 10x improvement in this technology yearly. And that either can be looked at as it's 10 times better, faster, or it's also cheaper. And so what we're likely to see as these systems improve is just greater applicability. Through the slide in, so the first graph kind of in the top left is just a graph of Moore's law. Moore he was an engineer with IBM way back in the day. Then he published this law, which kind of was showing the number of transistors on a chip was doubling every 18 to 24 months. And that actually extends to before Moore was around, even back when we used vacuum tubes to do computation. The power of computation has been doubling every 18 to 24 months for quite a long time. More recently, with accelerated computing, though, the rate of increase has become even more rapid. The bottom left slide is just a graph of different AI systems over the years, and it's just kind of showing the rapid rate of improvement of these systems. Just take note that the scale on the left is a logarithmic scale. So that's why the dots appear to be going up in a linear fashion. If this was a regular scale, that would also be kind of showing that exponential increase. And this paper actually just came out last Thursday or last Friday. And this new paper was kind of measuring the AI's ability to complete tasks that coders may do. And so they took a look at GPT-2, which came out maybe in 2019. And they noted that GPT-2 could do tasks that took coders roughly 2 seconds. And if you move up to Claude 3.7, which is a more recent LLM, it's able to accomplish tasks that takes coders about an hour. Of note, they were looking at a 50% success rate with this, however. And they did note that if they increase the burden to an 80% success rate, the curve is much slower. Even at 80% though, right? In the clinical setting, that is far, far higher risk rate than what we can tolerate in practice. But it just goes to show how quickly the capabilities of these systems are improving. There we go. So if we're looking at present day, what we're doing is we're seeing different specialized tools that are coming out for specific uses, but they have a lot of limitations and they require a lot of human oversight. Moving forward in the next couple of years, these systems will improve, particularly with use cases, particularly as cost comes down. And as these systems improve, they'll be incorporated more and more into different workflows and into medical care. And as we move forward, past 5 years, we'll start to see widespread implementation of these systems throughout essentially all of healthcare. But even at that point, it's very likely they're going to require very careful human oversight. And it's a little daunting to think 5 years from now, our students that are starting medical school will essentially have been using AI throughout all of high school and all of college. So this really is going to kind of become a standard, both for education, but also clinical applications. So AI familiarity is vital for the education of future healthcare professionals. This may put some of us in kind of an uncomfortable situation, particularly as we move forward a couple of years. A lot of these students may have much more experience with some of these systems than we do. But the future of medicine is predicted to really kind of grow alongside AI, and the use of these tools is going to become vital to practice medicine. What this means is current medical students need exposure to AI so that they're comfortable with it and they understand both the benefits, but also they're able to kind of mitigate some of the risks. Even our jobs as educators are likely to look quite different by the end of the decade. So as we're moving through, we'll start to see these AI integration, AI tools will start to become standardized in our workflows. And this will really kind of shift how things are done to more of a collaborative nature with AI. Because as we saw, this is developing so rapidly, this is going to require continuous learning on the part of educators, but also clinicians and students and so forth. And again, this is really going to kind of redefine how we practice in collaboration with these different AI capabilities. So as an example of how quickly things are changing, this paper came out maybe 3 weeks ago. And it's about Google scientists, and this kind of gives us a little peek into the future of research. There were scientists at the Imperial College of London in conjunction with Harvard. They spent the last 10 years trying to understand why certain superbugs gain resistance to antibiotics. And so they had finally come to their conclusion after studying this for the last decade. They then applied Google's co-scientist AI tool. And so this tool was able to analyze different sources of evidence, able to create its own hypotheses, create tests to test those hypotheses, and move forward. And in about 2 days, they came up with the same conclusion that the scientists had come up with. And it's important to note that their data was unpublished when they did this, so there's no way that the system was trained on or had seen any of their conclusions prior to this study. There is a little bit of a disconnect between kind of what's happening in the development world of AI and then what's happening in the clinical use of AI. This was a study back in 2021, but in this study, only 30% of radiologists at the time had reported using AI. And 70% said that they were reluctant to really kind of start using it and didn't really see much of a perceived benefit in this technology. And just as an example of requiring AI oversight, AI made this slide for me. And I didn't notice this until last night, but the second bar from the top, radiologists' reluctance, that's actually supposed to go all the way to 70%, and it didn't quite make it. And the other kind of important or interesting point from this paper that I found was academic centers are using and studying these technologies much more than community hospitals. So overall, current AI tools demonstrate impressive functionality in trials. So they're good at detecting findings on imaging or forecasting risks, for example. But their effectiveness in everyday practice is still being evaluated as more clinicians begin to kind of incorporate this technology into their workflow. The AAMC has published a framework for AI in medical education. And their two main pillars here is AI in medical education and AI for medical education. AI in medical education's focus is to support learners along their development in order to responsibly integrate AI into their practice, while AI for medical education focuses on building and incorporating AI into our tasks, processes, and systems. And so we're going to kind of apply this framework to some of the emerging tools and emerging AI tools in healthcare. There are three primary ways AI is currently being applied to healthcare. There are clinical applications, a lot of administrative functionality, and then also some educational tools. And this lecture is going to focus primarily on the intersection of these clinical applications and these educational tools. This paper by Russell and others kind of defined 6 core competencies for using AI in healthcare. There's the basic knowledge, AI-enhanced clinical encounters, workflow analysis, social and ethical implications, evidence-based evaluation, and practice-based learning. And so we're going to transition now into part 2. This is AI-driven tools in modern healthcare. So AI algorithms have shown performance comparable to or even exceeding specialists in certain specific tasks. However, these tools are not standalone. They require a lot of oversight for different reasons that we'll discuss. So essentially, these tools are turning out to function as just a very powerful assistant or kind of a co-pilot as we're moving through and using them in clinical care. So some deep learning models, and this is actually some of these tools have started coming out as far back as 2 or 3 years ago. But deep learning models can classify skin lesions, for example. There was one study that used an AI system to accurately diagnose melanoma from dermoscopic images, and it performed on par with dermatologists. And the system is even able to recommend appropriate treatment options. If we look at another example, AI and diabetic retinopathy detection. So there are FDA-approved AI systems to diagnose diabetic retinopathy. These systems can analyze retinal photos, and they achieved an 87% sensitivity and a 90% specificity for detecting more than mild diabetic retinopathy. So you can see how this is very useful for a primary care physician. Now, a primary care physician, if they're concerned about diabetic retinopathy, no longer needs to send their patients over to, the ophthalmology clinic, or maybe you are in a clinic for patients without insurance, and it would be very difficult to get them into an ophthalmology clinic. Now the PCP themselves can make this diagnosis and initiate treatment. There are lots of examples of AI in medical imaging. So in acute care, which is my realm down in the emergency department, there are platforms like Viz AI or Rapid AI, which are used to rapidly triage stroke patients. These programs can kind of analyze brain scans and differentiate strokes into different categories, such as flagging large vessel occlusions, which sometimes require different treatment than other types of strokes. And so what this does is it hopefully improves patient outcomes by reducing time to treatment as these patients come into the emergency department. If we zoom out a little bit, though, we can actually see that AI is involved in multiple steps when it comes to radiology. A lot of clinics and radiology groups are using AI to assist in patient scheduling to get scans. AI is used to optimize the scan. In particular, it can tone down the radiation, and so there's less radiation exposure to the patients as they're getting scans. AI has also been used to improve image quality. And then, of course, we just mentioned how AI can assist in reading some of these scans. And sometimes these AI systems are tied into the hospital communication or alert systems. So this information is being communicated to other providers like myself and the emergency department quicker than it would be if it was just a human reading these things alone. The radiologists are also using AI programs to assist with their reads, or essentially the document that they put out once they go through and read the CT scans. Radiologists then put that information into their read or their documentation, which is one of the ways that the information is disseminated. So AI systems are helping them with this documentation. And AI systems now are starting to tie in other patient data to help give treatment recommendations. And as we'll see, Gen AI now is also starting to be used to predict different outcomes and suggested treatments. In breast cancer screening, AI systems are reading mammograms. They have a sensitivity of 90% for detecting cancers. This is versus about a 78% sensitivity for radiologists. And another study out of South Korea found that some AI systems are better at catching early stage cancers, 91 versus 74% sensitivity. So if we take a look at pneumonia detection, and again, so this is an AI system, and the only thing that this AI system does is look at an X-ray and say yes, no for pneumonia, right? So it's not reading for all the other things that we're concerned about, like a pneumothorax or pulmonary nodules, and so forth. In this example, a convolutional neural network was used to detect pneumonia on chest x-rays, and it has a 96% sensitivity compared to a 50% sensitivity of the radiologists in this study. And the machine, however, only had a 73% specificity. So the specificity of the human reading the scan was better than the AI, but the sensitivity of the AI is better than the radiologists. And so these systems are kind of used to help rule out and triage x-rays. So the radiologists are potentially reading all of the x-rays that have pneumonia first and getting that information out to the clinicians and out to the patients. It's important to note that many of these systems have already undergone peer-reviewed evaluation and they have FDA approval. Moving on to AI-driven clinical decision support systems. These are being piloted throughout many hospitals for various different tasks. And we're going to go through a couple specific examples, as you can see here. Many of these systems are still in the very early adoption phases. There are virtual patient triage assistants or chatbots. This is another emerging tool. They're often used in telehealth and other kind of clinical scenarios where they can gather some of the patient histories before the patient meets with the practitioner and kind of streamline some of the triage process. And natural language processing systems or speech recognition tools are starting to, excuse me, automate documentation by transcribing clinical notes for physicians. A recent review found that these AI technologies are improving the accuracy and efficiency of clinical documentation. And what I, in particular, would appreciate about these tools is it's going to free up some time so I can spend more time at the bedside or more time with my patients and less time staring at a computer screen, typing away or dictating clinical encounters. But as you can see, there are a lot of other considerations. These notes that these systems are producing oftentimes include errors or inaccuracies, and so this still requires a very thorough physician oversight. Epic, for example, doesn't always play nice with some of these systems, and so there are a lot of integration issues. And of course, there are issues with data privacy, and some physicians may be a little less excited to use some of these programs as they may feel that it's taking away from some of their autonomy. So if we start looking at LLMs and augmenting clinical decision-making, so large language model-based systems have demonstrated an ability to synthesize clinical information and assist in diagnosis. GPT-4, for example, was tested in a study on complex medical case vignettes, and it correctly solved 57% of the cases. And that may not sound impressive, but it beat 99.9% of the humans who were reviewing. And this was both residents and attendings, but it beat 99% of the physicians who were reviewing these cases. There was a different study in JAMA that came out last November that found the availability of an LLM to physicians as a diagnostic aid did not improve clinical reasoning when compared to conventional resources. The interesting thing about that study was that the LLM alone actually had higher performance than all of the physician groups. And the conclusion from the study was actually that this indicates a need for technology and workforce development in order to realize the potential for physician and artificial intelligence collaboration in clinical practice. What this really suggests is that AI can act as a powerful diagnostic decision support tool. This will offer clinicians a second opinion or a list of possible diagnoses in challenging cases. An AI assistant could analyze patient symptoms, history, labs, all kinds of information, and it will then suggest potential differential diagnoses that either a trainee or an experienced clinician then can kind of compare to what they were thinking, and they may find things that they've overlooked or missed on their differential, for example. Other early use cases in the literature describe AI helping to identify rare diseases and flag misdiagnoses. So essentially, what we're looking at here is LLMs functioning as a high-powered extension of clinical reasoning. So these systems are not yet widely deployed on hospital floors, but they are being piloted in multiple institutions, very much under physician supervision. But they can help support decision-making, and there's already a lot of papers out with use in internal medicine and neurology, for example. AI models can analyze both historical and real-time patient data, and they can start to predict outcomes. This would be what's called predictive analytics. And so hospitals are using different predictive algorithms to identify patients, for example, at high risk of readmission, 30-day readmission for heart failure. Duke, I think, was the first hospital that I read that had a sepsis prediction model. And so this model was plugged into the electronic health system, and it was continuously reviewing all of the data like vital signs and lab results from the patients in the hospital. and it was successful at predicting patients who were going to decompensate or who were going to go on to develop sepsis. And Russia is working on a model here for us as well. So this is kind of an up-and-coming technology that we'll be seeing. So these AI-driven analytics are effective in both improving patient outcomes, but also in reducing costs. They can help target preventive interventions and get those interventions to the right patients, thereby reducing hospital readmissions or avoiding adverse events. A concern with these systems, however, is that they require very high-quality data. They require robust IT infrastructure and, of course, continued human oversight to verify that the outputs are accurate and that appropriate actions are taken based off of those outputs. In practice, what this really means is that interdisciplinary care teams, such as doctors, nurses, and data specialists, are all involved in the review of these AI alerts and risk scores during rounds. And understanding kind of what's behind this technology will help everybody kind of understand what to do with what the AI is recommending. This blend of predictive AI with clinical judgment is really kind of emerging as a powerful use case for patient management. And it gives us kind of another example of how AI can serve as kind of a co-pilot. So if we move towards medical students are starting to interact more and more with AI tools, particularly on their clinical rounds and their M3 and M4 years. And they're being used as learning aids and decision support resources. One example of this would be the use of AI-driven medical literature platforms. One that you guys may have heard of, we've talked about a couple times in this group, is Open Evidence. Open Evidence is an AI tool that many students now have access to and residents have access to. And this tool provides real-time evidence-based summaries of different clinical topics. So during rotations, a student can input different clinical questions, say, for example, how would I manage pancreatitis in a young pregnant female? And Open Evidence will rapidly search and synthesize relevant guidelines using different white papers and kind of present its research findings. And this is beneficial because it really helps students prepare for different cases. It gives them up-to-date information, and it's very efficient. There was a recent editorial by Patel and others where they noted that Open Evidence enables efficient search for different guidelines, diagnostic criteria, and therapies, streamlining decision-making and helping students prepare for wards. So let's go through one's potential and one is real life, two scenarios with technology like this. So scenario one, we've got an M3 who is on their internal medicine clerkship, and they're going through rounds, and the M3 might be asked about different treatment options for a diabetic patient. And so using an AI literature review tool, they can quickly pull up the latest evidence on different medications and treatment options. So this not only informs patient care, but it also helps reinforce students' learning with up-to-date and current literature and data. And scenario two, this was me when I was playing around with Open Evidence in the ER a couple weeks ago. I had a patient with severe DKA, and I thought I'd use this tool to kind of see what it had to say. And about 75 to 80% of what it had to say was correct. But it recommended that I give this patient an insulin bolus. And back when I was an intern, not to date myself, but very, very long time ago, the first paper started coming out showing that giving an insulin bolus in a patient with DKA increases adverse events, but has not been shown to improve patient outcomes. And so this really kind of presents a situation, where if a learner uses this tool and their presentation or their care plans contain some of these errors, that gives me an opportunity as a learner, or I'm sorry, that gives me an opportunity as an educator to kind of stop and discuss their care plan. And so really this is at this juncture in a clinical rotation, I can use that both to teach and learn about clinical medicine, but also this is a good opportunity to kind of teach and reinforce the evidence-based medicine that they've been learning in the first 2 years of medical school. So I would then, ask the student, well, why did you think we should give this patient an insulin bolus? How did you evaluate the literature? What were your sources? Are there better sources, and so forth? So we can kind of talk about and reinforce things that they've learned with respect to evaluating different literature. And incorrect suggestions and incorrect usage of tools isn't really a new problem. Blanketly accepting what an AI tells you to do is probably only slightly worse than reading the last sentence of an abstract or Googling something and using that as clinically useful evidence. The other benefits of these teaching tools and these scoring systems is that it has more time to work with the learner, say for in the ER, for example, than I do. And so let's say a learner needs to kind of bump up their understanding about ABGs, arterial blood gases. They can sit down with one of these tools and spend 15 minutes kind of talking about ABGs and learning how to calculate and understand an ABG. And then they can come to me as the educator, and I can really kind of go through and make sure that they understand this process correctly and identify any knowledge gaps and fix those gaps. And so it's my responsibility as a teacher to make sure that these concepts are appropriately understood and retained. But research to date shows that attending physicians in general are ineffective ourselves at using a lot of these tools. One common mistake I saw in some papers is that attendings tend to use LLMs, for example, as an answer machine, similarly to how you'd use Google. And what the problem with that is these tools don't have contextual understanding, and using them in that fashion makes it more likely that you'll get inaccurate answers. A couple other examples of some of these tools that you guys may be familiar with: Consensus or SciSpace. I'm not sure if anybody has used any of those. AI has also been used to assist in diagnostic reasoning as a learning experience. So clinical decision support AI, students can query this. For example, a student might present a challenging case to an LLM. They can discuss complex symptoms or unclear diagnoses, and a generative AI can kind of go through the differential diagnosis. So recent research shows that GPT-4, for example, and we kind of briefly talked about this paper already, but GPT-4 was able to analyze long case descriptions and often able to pinpoint the correct diagnosis. So it does a very good job working on different diagnostic puzzles. So the scenario for our learners might be a medical student on a pediatrics rotation maybe has a child with atypical symptoms. And so after the medical student formulates their own differential, they may consult an AI as a diagnostic aid. And this AI would help analyze the case and propose differential diagnoses along with giving its reasoning as to why each of those different diagnoses should be considered or how likely they are. So this gives the resident or the medical student an ability to compare what the AI is saying to their own, and they can discuss these discrepancies with the AI. And furthermore, they'll go on to discuss the differential when they present with the attending physician. And so they can kind of use this tool to fill in gaps in their clinical reasoning. In this way, AI is kind of acting as a digital second opinion for trainees. It kind of helps them consider alternative diagnoses and helps them learn from the vast training knowledge of the AI. And this really kind of is almost an extension of some of the tools that I used, but books that I used when I was particularly an M3 and M4. For example, when I was doing my ER rotation, I think the most helpful book that I used was a book that didn't break things down by system. It didn't break things down by treatment. Really, it broke everything down by chief complaint. And doing that really helps learners understand things more from a undifferentiated standpoint. You have this patient's here for chest pain. What do I need to think about? And then how do I go through and work that up? And these systems also do a very good job of breaking things down in that fashion and help students learn in that manner. AI simulations are also being used to develop clinical reasoning skills. They can model different diagnostic processes and help with treatment selection. These systems can present students with challenging cases and guide them through what the appropriate diagnostic workup is. And this really helps learners in the clinical setting integrate all of their information and things that they've been learning. So LLMs also can be utilized for personalized learning. So students may start to use LLMs to help them prepare for different clerkship exams or boards. They can use it to come up with study plans that's tailored to their strengths and weaknesses. They can have it make quizzes, and they can instruct the model to kind of focus on areas where they're struggling. So the model can remember the questions that they're getting right and wrong, and then really kind of delve deeper into the subjects where they are performing poorly. Students may use Notebook LM to make podcasts and different things, to use it for different modalities for learning. They can use their notes, for example, to make a podcast. And even more recently, Notebook LM now will create mind maps. And so that really gives students another way to kind of organize the information that they're trying to learn. And lastly, your motivated learners might take all of the feedback that they're getting from classes or clinical rotations. They can load that into ChatGPT and have ChatGPT give them clear, actionable steps to improve their performance on rounds. These interactions illustrate that when used appropriately, AI can enhance learning by providing timely information and feedback, and can be a safety net for clinical decision-making, all while students maintain the responsibility for understanding and verifying the information given to them. This was a paper that actually came out a couple years ago by Ethan and Lolik Malik, talking about using LLMs in the classroom. And they broke this down into understanding, and these are things that we should tell our students when we're having them use LLMs for homework or in the classroom. And they broke it down to understanding the limitations, effective interaction strategies, and documentation requirements. And so we should tell our students that LLMs, for example, can give unpredictable outputs. They can suffer from hallucinations. LLMs are not a person, and so they shouldn't treat them as such, and that students are always responsible for their work. And we should remind them to only share things with the LLMs that they're comfortable with, because that information may be used later on in training. Their recommendations for interaction strategies include being direct and providing as much context as you can, seek clarification if the output doesn't necessarily make sense. And sometimes the LLMs get stuck in loops or kind of get off topic. And so as the user, they should maintain control. Sometimes they'll need to summarize previous interactions to provide context, and they can ask for different connections between ideas and topics, and they should challenge responses, particularly if they disagree with the answer. And then on our side, the education or the educator side, we should have them share their work, their interactions with the LLM, and we could even have them, write a paragraph reflecting on the experience of using the LLM, and we should keep track of what is and isn't working. This paper, I didn't include the entire paper, but if you are looking at using and applying LLMs to the classroom, they gave 7 concrete uses, and I gave a couple examples here. I won't go into incredible detail, but if you'll notice, there is a rubric to kind of how to use these LLMs. You break your prompts down into different sections, such as roles, step-by-step instructions, constraints, and different things that you can do to personalize the output. And applying this rubric will really help prevent things like hallucinations. And this actually isn't medical. I got this picture out of a daily kind of AI newsletter that I get, but it does a nice job of summarizing a lot of different ways that learners are using this. I use it a lot to simplify or break down complicated topics. You can always ask it to explain something to you like you're 5 years old and then like you're in college. And each time you move up, you get kind of a more granular or fine understanding of what the topic is. You can use it to give you analogies. You can have it role play. And this isn't just a human. You could have it take on the role, for example, of a protein. And it can kind of go through and you can talk to it like you're talking to the protein, and that can kind of help you understand what it's doing intracellularly, for example. We mentioned quizzes and mind mapping and so forth. I also talked to a colleague, Dr. Patwari, who does a lot of education, and he's been using it quite a bit to brainstorm and come up with topics. He may put the course outline into ChatGPT and ask it if he's missing anything, and it may come up with some other topics that he should cover. Sometimes we can use it to come up with clinical cases. You can have it fill in a lot of the details, while us as the educator can focus on the higher level aspects of the case for teaching. It doesn't always do a very good job of coming up with summaries and outlines. When it does this, it frequently omits important details. And he also uses it for making tables and documents. You can upload source material into it and have it come up with a table or a document. You can dictate what you want the rows and the columns to specify. So really now we're kind of moving into part 3, which is best practices for teaching AI in clinical education. And so integrating AI into medical curricula is becoming more and more essential to prepare our future physicians. In one study, however, 71% of medical students agreed that they need formal training in AI, and AI is a critical component of medical practice. And so a lot of the different sources and papers that I looked at really suggest that AI needs to be introduced early and built upon longitudinally throughout the curriculum. Really, what this means is integrating AI use with other core components throughout the medical curricula. And this approach will empower students with first principles that will enable them to enable them to assess and adapt to new AI systems as they're developing. There's an analytics hierarchy, which provides a useful framework for organizing AI concepts in medical education. And this hierarchy consists of three levels. There is descriptive analytics, which is summarizing and integrating information. The next level of AI is predictive analytics, and this is when it's used to estimate unknown information based off of a set of given or known information. And then the highest order would be prescriptive analytics, and this is when AI provides treatment recommendations for actions. And so applying this framework kind of helps students build upon and connect different gaps as they progress through medical education. And each level kind of builds upon the one below it. So medical education models will start to position AI as a co-pilot for students and faculty. This approach, particularly if started early in medical school, will help normalize AI as a collaborative tool rather than a replacement for human judgment. This will help students develop appropriate reliance on technologies. So not over-reliance, but also not scared or under-reliance. And so medical education should emphasize knowledge management rather than just information acquisition and rote memorization. This approach recognizes that AI can handle a lot of our information retrieval tasks, allowing human beings to focus on applying this knowledge in different clinical contexts. Again, this is more of an extension of the path that medicine has already been on. When I was in medical school, I think I had to memorize the Krebs cycle and all these sorts of things, right? But really, for future clinicians, it's probably less important that they memorize every single aspect of the heart score or the TIMI score, for example, but it's very important that they understand how to apply this correctly. We all have tools on our iPhones for the last 20 years that have had a lot of these scoring systems on it. And so we can use the tool to come up and calculate the score, but then as a clinician, we really need to understand the usefulness of that score. How accurate is this score? How much should this score change my clinical management for this patient and so forth? Again, medical students need to have the appropriate tools and knowledge base to question different AI recommendations, and they really need to be able to look up primary literature and apply critical thinking to assess the literature for themselves. There are a lot of nuances to clinical medicine that AI is completely clueless on. AI does not have these critical thinking skills that our graduates need to have. And AI, for example, doesn't always distinguish good articles versus bad articles or good data or old articles versus new articles, right? For example, when I was using open evidence and it was recommending giving the insulin bolus for my GKA patient, it must have been using a paper published more than 20 years ago because it's been standard of care for the last 15 years to not give that insulin bolus. And a lot of times AI is just kind of regurgitating study conclusions. And so it's not really evaluating how well that study was performed or how effective that data is. So educational leaders and accreditation bodies have started to outline different strategies for AI education at both the medical students and residency levels. So we need to define core competencies. Curriculum developers should establish a clear set of learning objectives for AI in medicine. Students need to understand the fundamental concepts like machine learning versus rule-based algorithms, data biases, and model validation. Defining these competencies creates a structural framework that can be embedded into existing courses. For example, medical students might be expected to interpret some AI output, such as a risk score, but to do this, they'll need to understand its limitations. And so these types of competencies, as you can imagine, would fit really well and can be taught right alongside evidence-based medicine. We can use case-based learning. So teaching AI is most effective when abstract concepts are tied to clinical scenarios. Educators are encouraged to incorporate case studies or clinical vignettes that involve AI. One example I saw would be examining a case where an AI diagnostic tool succeeded or failed, and students can kind of evaluate this tool in order to grasp different issues like external validation and biases. One workshop had students analyze implementation of AI systems for diabetic retinopathy, for example, and then they had them identify different barriers and challenges for moving from bench to bedside. A lot of these different articles emphasize experiential learning. This would be hands-on experience with AI tools, and this is very important. One example or one way that we could apply this would be a flipped classroom, which I know a lot of classes at Rush have started experimenting and using the flipped classroom. So in this situation, students first would have an assignment where they would learn the theoretical aspects. Perhaps they would take some online modules on neural networks or data ethics, and then they would come to classroom or lab time, and the classroom or lab would focus around practical exercises. So students might use a simple machine learning model, for example, in classroom or in lab to predict outcomes from a data set. Or residents in their rotations, residents maybe have different electives that they could take like AI in healthcare, where they can work with actual effective clinical AI systems, again, under attending supervision. But the deliberate practice and doing this throughout medical school and residency will help demystify AI and build competencies in interpreting AI outputs. Another topic is integrating interdisciplinary and team-based training. So AI in healthcare is inherently interdisciplinary, right? It kind of functions at the intersection of medicine, data science, and ethics. And so our education should reflect this by also involving multiple disciplines. We can have workshops or lectures where we have data scientists teaching technical aspects along with clinicians teaching the clinical aspects of different AI applications in healthcare. And by incorporating these strategies, foundational knowledge, case-based context, hands-on practice, and interdisciplinary learning, medical education will produce clinicians that are AI literate and able to safely leverage AI tools to improve healthcare. There are a lot of ethical and safety considerations. We'll go through this a little bit more, but we don't have a lot of time to go very in depth. But it's important to note that these systems can have algorithmic biases. This is actually a big issue in AI and healthcare. So if systems are trained on data sets that are not representative of the patient population at your hospital, for example, it's going to give incorrect outputs. If AIs are, say, for example, trained on data where a certain population of people receive different treatment, but not based on literature, but more based on current biases in our healthcare system, that AI will learn those biases and then purport that as standard of care treatment. And so we have to be very vigilant about recognizing these biases. There's also issues with patient safety and accountability and data privacy, as you can imagine. And this is just another slide kind of going through some of these issues. There's also regulatory compliance. And this is an up and coming issue, right? So the current methods for FDA approval don't really take into account the fact that a lot of these tools are continuously changing and continuously learning. FDA was kind of set up to evaluate static things like drugs. So hopefully, as we move forward, there will be better and more clear guidelines as to how to apply these tools and gain FDA approval. If we transition back to the educational arena, AAMC has published a series of principles to help guide medical education. And this focuses on seven different kind of main topics. They recommend maintaining a human-centered focus to ensure ethical and transparent use, provide equitable access to AI, and foster education, training, and continued professional development. They also suggest interdisciplinary collaboration, data protection or privacy, and then continuous monitoring to evaluate the effectiveness of these systems. I'm going to move through this fairly quickly. There's another regulatory body, the IACAI, which actually is an international collective. It involves the AAMC along with similar organizations from other areas like Europe. And they've kind of gone through and given a list of recommendations as well. And we'll just kind of quickly move through this. So they have recommendations with respect to values, culture, and integration. They also state that medical educators must develop AI literacy in order to enhance teaching, research, and clinical decision-making. They discuss different ethical frameworks to guide responsible use of AI in medical education, focusing on academic integrity, transparency, and privacy. They mention that institutions need to continuously adapt new AI tools, evaluating them for their strengths, biases, and limitations while ensuring equitable access. And that is equitable access to all of our learners. So some learners don't have more access while other learners maybe suffer. So this should be ubiquitously applied and available for everybody. 5 was AI can improve different teaching methods, it can support critical thinking and medical decision making. At 6, AI can enhance clinical training and skills development through various applications that we've discussed. AI-powered systems can improve assessment with different protocols. This requires human involvement, particularly to mitigate bias. AI assistants can be used to streamline curriculum, learning analytics, and educational content to create more effective learning experiences for our students. AI can provide support for research mentorship and exploration by helping to optimize our research processes. And lastly, medical education should prepare a workforce that is ready to collaborate with AI across multiple disciplines. And AI can also enhance self-actualization, self-care, and health monitoring while promoting humanistic environments. So that was kind of a nice review of what we've covered so far. With the last couple minutes, we're briefly going to talk about challenges and opportunities that are on the horizon with AI. So as you can imagine, there are technological and data limitations. AI algorithms are only as good as the data and the design behind them. Many healthcare data sets, however, are fragmented, small, or of variable quality, and this limits AI performance. In a review I read, 42 studies cited data issues as being one of the major barriers for AI deployment. And so, as I mentioned earlier, if AI is trained on a narrow population or on outdated information, it will not generalize well, and it won't give good recommendations. Integrating AI systems with existing hospital IT infrastructure can also be difficult. Oftentimes, there's lack of interoperability with electronic health records or other tools. And many current AI tools also lack explainability. And it's difficult to trust what an AI is telling you if it's a black box and you don't understand how it got to its conclusions. What this means is that there are substantial IT developments that will be required in order to kind of institute a lot of these systems. The human factor is also a significant barrier. Many clinicians and instructors are hesitant to adopt AI tools due to limited familiarity and fear of unintended consequences. Studies found that education and training of the healthcare workforce is a prominent concern, noted in dozens and dozens of articles. Currently, detailed knowledge of AI among practicing clinicians remains rudimentary, and without sufficient training, providers may be uncomfortable or very skeptical about using some of these programs. There is also apprehension about AI encroaching on professional roles. Some practitioners worry that AI could replace parts or all of their job. And one survey, a notable fraction of healthcare professionals expressed fear of job displacement due to AI. But experts note that AI is much more likely to re-engineer workflows than eliminate jobs. And overcoming resistance to implementation requires targeted education that we've kind of been discussing throughout this lecture. Embedding AI seamlessly into clinical workflows is going to be challenging. It's not enough for an algorithm, for example, to be accurate in a lab, where a lot of these kind of tools are born, right? AI tools have to fit into the fast-paced, complex work environment of patient care. There are often usability issues and problems with fitting this into different workflows. And a lesson from Epic, right? So if there's an AI alert system that produces too many false alarms or it's not well integrated, then physicians are likely to not use it, and these systems will be ineffective. There are also oftentimes implementation costs and resource constraints. Acquiring AI technology and training staff to use these tools can be expensive and time-consuming, which is a big barrier for us in healthcare. So change management is needed in most facets of medicine. So we'll be redesigning workflows. Without thoughtful integration, even the best AI tools will be unused. And a lack of clear standards and guidelines for integration means that many institutions right now are trying to figure this out on their own, which is inefficient if everyone's trying to reinvent the wheel. So this requires diverse collaboration across different specialties, particularly with clinical end users that can work on design and iterative testing with emphasis on iterative testing and retesting. And this will help ensure that we can integrate this into our IT systems and different departments. The challenge here, though, is fitting AI training into an already packed curriculum in med school or in residency is going to be a big hurdle. Healthcare professionals need to understand how these AI systems reach their conclusions in order to trust the outputs. We kind of talked about the black box problems. But students also need to understand how AI use affects informed consent process and patient autonomy. Education should cover how to effectively communicate with patients about using AI-assisted care decisions, and also how to respect patient preferences regarding AI use. So as we're moving forward, I think what a lot of these guidelines are really saying is, as educators and clinicians, we need to start asking ourselves, how can I use AI to do this process or do this project? And then we all need to kind of go out and start using it to really kind of understand what is and isn't working for us. And early on, we should be pushing our students to do the same. Interdisciplinary implications. So AI's impact in healthcare extends to all allied health professionals, not just our physicians, but nurses, pharmacists, lab technologists. Everybody will be interacting with these tools. And so as we're teaching this and as we're kind of going through and building these tools, we really need input from all these different aspects of healthcare. A survey has shown that while allied health employees are very optimistic about AI's potential, almost everybody feels underprepared. In one cross-sectional study of 11 different health professions, 80% of the respondents stated that they had never used an AI tool, and almost 90% reported little to no knowledge about AI. So all these participants agreed that AI could improve patient care, enhance clinical decision-making, and impact their role in healthcare. But they needed exposure and they needed education. Again, this is just kind of going back to the interdisciplinary collaboration. So as we're teaching these things and we're building these tools, we need input from each of the different groups of allied health professionals to make sure that these tools are effective and make sure that everybody's on the same page with how to use them. And those are the sources that I've used to kind of come up with this lecture. If we have a couple minutes for questions, if anybody has anything they want to talk about.
Thanks, Jessen. Yeah, there was a question in the chat asking if you could collaborate on the ongoing AI project at Rush in terms of the tools and what compliance looks like for that.
Can you be a little more specific? I
Yeah,
think
that was earlier in the presentation. I think you mentioned about Rush creating its sort of own AI environment or system. And I think the question was asking if you could tell us a little bit more about that.
unfortunately, they may be referring to the sepsis model, and I'm actually not on that. I'm not on that project. There are a couple AI projects that I'm working on, and so those projects involve meetings with our IRB, for example, because we'll be doing research. I've also met with our cybersecurity team. I've had a couple meetings, and I'll be working with IT to kind of set up some of these systems to start testing clinical uses. The first one that I'm working on, I've mentioned a couple other times at some of these meetings, is kind of a documentation aid. And so it's going to be based on Copilot, and users will be able to enter general information into the tool, and the tool will kind of help them with their documentation and help them make sure that the important elements are included so that the chart is graded at and achieves the full potential for billing. And there are other ones out there, such as discharge summaries and other things like that. And at Rush, all of these tools, particularly if they're going to be used in the clinical setting, will have to go through a similar approval process with meetings with our cybersecurity team to kind of get approval. And so the cybersecurity team, for example, is very concerned with data privacy and making sure that, like, pertinent health information isn't disseminated into these tools. I don't know if that's the answer you guys were looking for.
Yeah, thank you for your answer. This is a question raised by me because just now when you do your presentation, you mentioned you have some AI project. Just the interest to know how you do those AI project, and then also do you collaborate with any AI engineer or not?
Yeah, as we're speaking, I'm kind of laughing to myself because a lot of this presentation was about collaboration with other specialties, and the stuff I'm working on, I've not really collaborated much with other departments. That said, as I'm working through and gaining approval with our cybersecurity team, one of the things that they've kind of asked about is scalability. And so if this tool proves useful in the emergency department setting, it'll be very easy to kind of scale this out to other departments. And so at that point, I may collaborate with, say, medicine or surgery or somebody, and then they can start using a similar tool that's specialized for their specialty. And so, yeah, I guess my projects are still kind of at a very early phase, but the sepsis model that they're developing, I think they're pulling in information from the clinicians, from our intensivists. There are computer scientists and data scientists who are building out the models, where the clinicians are less involved in the actual process of building the models and more involved with kind of setting the goals and figuring out how to integrate the models into the clinical workflow. But then there are pharmacists who are probably involved in that, and their involvement is to help the model decide which is the correct antibiotic for those patients. And then there's nursing input, particularly with respect to what types of alerts are going to pop up in Epic, so we don't have alert fatigue, so to speak. So alerts aren't popping up every 5 minutes. The alerts need to show up at the right time in the EHR, so it's not interrupting your workflow and that sort of thing.
So does that mean you use a previous patient data to predict, let's say the patient have sepsis, and you basically build like a scoring tool, like APACH2 score. So then any patient, the number is exceeding one number, so then you will pop up the alarming for the clinician. Am I understanding correct?
Yes, correct.
Okay. That's interesting.
I think so. Yeah.
But I think this is good attempt. I mean, because we're all interested to know how AI can help us, but everybody is kind of at a very early phase, don't know what's going on and how to apply those information, and we're all worried about if this information is accurate or not.
Yeah, and that's That's the big concern. If like inaccurate data or wrong data is used in training these models, then the outputs will be incorrect. And so that's the big challenge. Yeah.
Yeah, just one more thing. I mean, so just now you mentioned about, some of the recommendations based on old literature, or maybe just based on those abstract only. I'm thinking probably because a lot of medical literature are not of open access, are not available. So probably those AI tools, there's no way for them, there's no way to read or review those full text of the articles. Only can access is the abstract. Another thing is probably the AI tool cannot differentiate the quality of the study. For example, if the evidence from randomized control trial versus a small sample size observation retrospective study, definitely the quality of level is completely different. I think probably that's why, we have to cautiously use a conclusion from AI.
That is precisely the reason why teaching our students and our residents these critical thinking skills is becoming more and more important as we move forward with this technology. You're exactly right. Sometimes open evidence or perplexity or whatever is essentially just restating what the study conclusion was. And as you know, sometimes the conclusions that the authors of studies reach aren't necessarily the conclusion that I'm reaching when I review the data and methods and so forth, right?
Yes. Great. Thank you so much for this great presentation. I can say that I attended the Critical Care Medicine, Society of Critical Care Medicine annual conference. I attended multiple AI talk sections. I think yours is the best, even better than the national conference, I think.
Thank you very much.
Thank you.
Thank you.
Bye.
Bye. Did anybody else have questions?
Adam, did you have a question? I know Emily had to jump off, so I told her I would wrap things up. Thank you so much, Jessen. That was fantastic. I learned a lot today.
Thank you.
If there are no other questions, I think we can conclude the meeting. And I put a note in the chat about our next AI talk featuring Dr. Adam Wilson, who's on the call. So that will be April 8th from 12 to 1. So thanks again, and I'll see you all around.
Great. Thank you.
Thanks.
Bye.
Bye.